Hello and welcome. Today we're delving into a rare and complex condition known as a vesicorectal fistula. This video will explore what it is, what causes it, how it's diagnosed, and the available treatment options. Join us as we unravel this intricate medical challenge. So, what exactly causes a vesicorectal fistula? This abnormal connection between the bladder and the rectum can arise from a variety of factors. In adults, the most common culprit is diverticulitis, an inflammation and infection of pouches in the colon, particularly if it perforates or forms an abscess that erodes into the bladder. Other potential causes include complications following colorectal or pelvic surgery, such as low anterior resection for rectal cancer, bladder cancer, radiation therapy to the pelvic area, inflammatory bowel diseases like Crohn's disease, traumatic injuries to the pelvis, or even a foreign body lodged in the rectum that erodes into the bladder. In children, vesicorectal fistulas are quite rare and are usually associated with congenital anorectal malformations, conditions present at birth involving the rectum and anus. To understand the impact of a vesicorectal fistula, we need to consider its pathophysiology. Essentially, it creates an abnormal channel between the bladder and the rectum. This allows urine, which should be sterile, to leak into the rectum. Conversely, fecal matter and bacteria from the rectum can enter the bladder. The continuous flow of urine into the rectum can cause irritation, inflammation, and ulceration of the rectal lining. More significantly, the introduction of fecal bacteria into the bladder leads to recurrent and often antibiotic-resistant urinary tract infections. This constant contamination can severely compromise bladder function and overall health. Vesicorectal fistulas are considered rare conditions. Accurate epidemiological data is difficult to obtain because many cases may be undiagnosed or misdiagnosed, or due to the variety of causes. The incidence varies depending on the underlying cause. For example, the incidence after low anterior resection for rectal cancer can range from 1% to 5%, depending on the surgical technique and patient factors. In regions where inflammatory bowel disease is more prevalent, the incidence related to Crohn's disease may be higher. Congenital vesicorectal fistulas are extremely rare, occurring in a small percentage of infants with anorectal malformations. The signs and symptoms of a vesicorectal fistula can be distressing and significantly impact quality of life. Pneumaturia, or the passage of air in the urine, is a classic symptom, often described as bubbles when urinating. Fecaluria, the presence of fecal matter in the urine, is another hallmark sign. Patients may also experience recurrent urinary tract infections, often accompanied by abdominal pain, pelvic pain, and dysuria or painful urination. Rectal irritation, diarrhea, and the passage of urine through the rectum can also occur. In some cases, patients may experience vague symptoms such as fatigue, malaise, and unexplained weight loss due to chronic infection and inflammation. Diagnosing a vesicorectal fistula requires a thorough medical history, physical examination, and a combination of diagnostic tests. A urinalysis can reveal evidence of infection, such as white blood cells and bacteria. Cystoscopy, a procedure where a thin tube with a camera is inserted into the bladder, allows the doctor to visualize the bladder lining and potentially identify the fistula opening. A colonoscopy, which involves inserting a similar tube into the rectum, can help visualize the rectal lining. Imaging studies, such as a CT scan or MRI of the pelvis, can help identify the fistula tract and assess the surrounding tissues. A cystogram or voiding cystoarthrogram, where contrast dye is injected into the bladder and X-rays are taken, can also help visualize the fistula. Methylene blue dye installation into the bladder can be used to see if the dye appears in the rectum, confirming the presence of a fistula. While vesicorectal fistulas are not strictly classified into types, they can be categorized based on their etiology. As we discussed earlier, they can be congenital or acquired. Acquired fistulas can be further classified based on the cause, such as post-surgical inflammatory, radiation-induced, or traumatic. The location and size of the fistula can also influence treatment decisions. The treatment of a vesicorectal fistula typically involves surgery to close the abnormal connection. The surgical approach depends on the size, location, and cause of the fistula, as well as the patient's overall health. Smaller fistulas may be amenable to minimally invasive techniques, such as laparoscopic or robotic surgery, which involves smaller incisions and potentially faster recovery. Larger or more complex fistulas may require open surgery. The surgical repair often involves separating the bladder and rectum, excising the fistula tract, and then closing the openings in both organs with sutures. A tissue flap, such as a muscle flap, may be used to reinforce the repair and improve the chances of successful closure. Prior to surgery, antibiotics are often administered to treat any existing urinary tract infections. A temporary diverting colostomy, where the colon is diverted to an opening in the abdomen to allow the rectum to heal, may be necessary in some cases. Post-operative care includes monitoring for infection, pain management, and ensuring adequate bowel function. Preventing vesicorectal fistulas is not always possible, but certain measures can reduce the risk. Proper surgical technique during pelvic and colorectal procedures is crucial. Careful management of inflammatory bowel disease, including medication and lifestyle modifications, can help prevent fistulas related to Crohn's disease. Prompt treatment of diverticulitis can prevent complications such as abscess formation and fistula development. For patients undergoing radiation therapy to the pelvis, careful treatment planning and techniques can minimize the risk of radiation-induced fistulas. Avoiding traumatic injuries to the pelvis can also help prevent fistulas. The prognosis for patients with vesicorectal fistulas depends on several factors, including the underlying cause, the size and location of the fistula, the patient's overall health, and the success of the surgical repair. With appropriate treatment, many patients can achieve successful closure of the fistula and resolution of their symptoms. However, recurrence is possible, particularly in patients with inflammatory bowel disease or those who have undergone radiation therapy. Recent research has focused on improving surgical techniques, such as the use of tissue flaps and minimally invasive approaches, to enhance the success rate of fistula repair. Studies are also investigating the role of biological materials and tissue engineering in promoting tissue healing and preventing recurrence. Furthermore, advancements in imaging technologies are aiding in the early and accurate diagnosis of fistulas, leading to more timely and effective treatment.